I'm going to talk today about beta-hydroxybutyrate. I do have some disclosures just so that you're aware. I have spoken on this for a couple of different companies, Abbott, Instrumentation Labs, Roche Diagnostics. I do volunteer and have presented for the Clinical Laboratory Standards Institute, and I have presented for Stanbio Labs in the past. So the objectives today, I want to describe diabetes. I really want to review ketone bodies and the pathophysiology of diabetic ketoacidosis, and then identify the clinical utility of beta-hydroxybutyrate. So let's start with glucose. The brain needs about 150 grams of glucose a day just to function. And the remainder of about 40 grams that is necessary to keep our bodies operating is spread throughout the rest of our tissues. Highly metabolizing tissues have enormous glucose requirements, and that's why we store glycogen. Glycogen in the liver so that it can be released slowly over time, and we can maintain stable glucose levels in our bloodstream. But not all cells, like the liver and the muscles, can store glycogen. So the brain, the red blood cells, the heart, the kidney, and the lens of our eyes don't store glycogen. They require glycogen from the liver and from the muscles and from production of glucose by metabolism of fats or proteins when we're in a fasting situation. So insulin. Insulin is mandatory for cells to actually uptake glucose and to utilize glucose. It was discovered in 1922. It's released from the beta cells of the pancreas in response to high levels of blood glucose or rising levels of blood glucose, or vagal stimulation, hormone release like GIP, or certain amino acids. It regulates the number of glucose transporters that are expressed on the cell surface, and it actually also activates within the cells the kinases that can actually metabolize glucose. So it acts almost like a gradient to absorb and push glucose from the bloodstream into the cells. And I just pulled this out of the Eli Lilly archives. This was in 1992, one of the first patients that was actually treated with insulin. You can see a 3-year-old boy with type 1 diabetes before and then 3 months after treatment with insulin. So almost the starvation status, the fact that even despite you have high levels of glucose, you're almost in a fasting type of situation without glucose around. Now, fats. Fat metabolism actually is utilized to maintain glucose when we go into a fasting situation. So when we are fed, insulin and high blood glucose actually stimulates release of insulin. Insulin is taken up and it's actually converted and stored in our adipose tissues as fat for later time and later use when we actually go into a starvation. So insulin activates lipoprotein lipase. Fatty acids are stripped from the chylomicrons, the VLDLs, taken up by the adipose tissues and stored for later use. That's in the fed state. Now in the fasting state, we see decreases in insulin and rising glucagon. This activates a hormone-sensitive lipase that reverses that buildup. It strips fatty acids off of the storage, metabolizes fatty acids, and condenses them to actually convert the long-chain fatty acids into ATP and energy, and convert the glycogen stores into glycerol and glucose. So this kind of summarizes things quite well. After we eat, we have high levels of glucose that decrease in the hours just after eating because that glucose is taken up by the cells and particularly by the liver, converted to glycogen stores for later use. So we see glycogenolysis after glucose starts to decrease, glycogen is broken down, and then that is used up within about 24-36 hours. And it is then, over the next several days, as you go into fasting, that the breakdown of protein and fatty acids is converted into glucose, this gluconeogenesis that occurs. And we can see traces of that because the rise in fatty acids in our bloodstream parallels the decrease in glucose and the rise in ketone bodies. And I'll discuss this more later in the talk. But that really brings me to what is diabetes. Diabetes is a metabolic disorder characterized by chronic high levels of glucose, with disturbances in carbohydrate, protein, and fat metabolism. So it arises from really a problem with insulin processing. It is either a deficit in production, a deficit in release, or a deficit in effective action on the cells, or some combination of all three of these. The consequences of having too little insulin or ineffective insulin is really high levels of blood sugar. And when you have circulating high levels of blood sugar, that sugar can actually bind to proteins, it can bind to membranes of cells, it can alter those proteins, and it is this binding that actually leads to the long-term risks of neuropathies, renal damage or renal impairment, the nephropathies, the retinopathies that's due to both microvascular and ultimately lead to cardiovascular problems that lead to the MIs, the strokes, the macrovascular complications. So two types of diabetes. Those that are early onset, type 1 diabetes, used to be called juvenile onset. These are primarily because it's immune-related or autoimmune response and attack against the beta cells of the pancreas. So it's caused by cell-mediated autoimmune destruction of the beta cells, and it presents in pediatric young adults with an insulin requirement for life. There is now the type 2, which is the predominant form. More than 90% of the diabetics are type 2, and this was previously called non-insulin dependent diabetes or adult onset. And it is a combination of both insulin resistance, not enough receptors on the cell surface, or ineffective production. So the pancreas keeps pumping out insulin in response to the fact that glucose is rising. Cells are giving off a starvation type of response, and yet that insulin isn't acting on the cells. So this sort of summarizes what we have mentioned. The paramount problem here of insulin deficiency leads to both protein breakdown and release of amino acids so that you can convert those amino acids, gluconeogenesis, into glucose. So we have increased protein catabolism or breakdown. We also break down from the fat cells our lipids and convert those lipids through gluconeogenesis into glucose. And the consequence of both breakdown of protein and lipids is an increase in ketones, an increase in fatty acids circulating in the bloodstream, and a hyperglycemia. That as this hyperglycemia overcomes the renal threshold, starts to dump out into the urine and take water with it. So you end up with not just a loss of glucose from the bloodstream, a breakdown of your muscle cells, breakdown of the fatty acid stores, and dehydration. So it's almost like a vicious cycle that gets set up. So what's the significance of ketone bodies? Obviously, we see them in the fasting status, and they continue to rise sharply within the first few days, and then plateau after about 20 to 30 days as we see fatty acid breakdown to replenish the glucose stores and glucose needs in the body. Now, beta-hydroxybutyrate and ketone bodies are not normally seen in measurable quantities in the blood or urine. Their presence indicates that the body is now relying on fat as its main energy source. But it's not necessarily indicate that the patient has diabetes, because there's other consequences, and we'll discuss those later in the talk. So what is diabetic ketoacidosis? It's a life-threatening complication of untreated diabetes or chronic high blood sugar. It's due to insulin deficiency and stress hormones that cause a combination to combine to cause diabetic ketoacidosis. It was once thought to be the leading cause of death amongst type 1 diabetics before insulin was available. And even today, in developed countries, diabetic ketoacidosis has a high significant morbidity and mortality. It's characterized by hyperglycemia, acidosis, and the presence of ketone bodies. It is mostly type 1 diabetics that present with DKA, but type 2 can also show DKA under extreme stress, like serious infections, post-trauma. Young, predominantly over old, females over males. And it's the most common cause of death in diabetics less than 20 years old. 1 out of every $4 is spent on direct medical care for adult patients with type 1 diabetes. And annual hospital costs in the US for diabetics is over $1 billion. The mortality in DKA is most commonly due to the underlying cause that precipitated the DKA event, and not due to the acidosis and metabolic imbalance itself. But it starts that vicious cycle that unless you get rid of the precipitating cause, that initial illness, it's going to escalate and become more severe. So in 2003, the CDC National Diabetes Surveillance Program noted that there was about 115,000 discharges for DKA in the United States. And you can see these rising numbers. This isn't necessarily due to an increased prevalence, but an increased diagnosis and realization that DKA is a treatable illness and a necessary complication of diabetics when they're admitted to the hospital. So what is the clinical presentation? The clinical presentation, classic, it's polydipsia, polyuria, and polyphagia. So thirst, urination, and hunger. Vomiting, abdominal pain, and kussmaul, or these deep respirations, are increased. Signs of dehydration, weight loss or muscle wasting, fruity medicine breath, the acetone breath, and cerebral edema and eventual CNS depression and coma if left untreated, and continues to escalate. So what's a typical case? I'm going to talk about a couple of different ones, but this was one that presented to our emergency room. It was a 9-year-old boy. He came to the clinic with a 6-day history of stomach pain, diarrhea. The doctor, his primary care physician, saw him. Vomiting started about 2 days ago and has persisted. So he presented with weight loss. His heart rate was 140, respiration 28. Temperature was 97.8, so not significantly elevated. But he was anorexic, 59 pounds, tacky mucous membranes, his abdomen was soft, positive for urine blood sugar, and mild left tenderness. And he was diagnosed with viral gastroenteritis with mild dehydration, discharged, but then seen in the ER 24 hours later. Now, detected, low weight, quiet, tired, uncooperative, positive for acetone breath, and he went severely downhill from there and passed. So he was not caught quickly enough and was already showing signs of cerebral problems. So the etiology of DKA, it violates the rules of common sense. Increased insulin requirement despite decreased food intake, marked urine output in the setting of dehydration, and breakdown of protein and fats, this catabolic state, in the setting of hyperglycemia and hypertriglyceridemia. It's precipitated, as I mentioned, by stress. So that causes an increased hormone secretion, glucagon, cortisols, catecholamine response. And some common stressors are common diseases: pneumonia, UTI, gastroenteritis, as we saw with the patient before. Pancreatitis can be post-trauma, like an MI or a stroke. Alcohol and drug abuse, particularly in known diabetics. And these are some of the protein or hormones that are released in response to the pathophysiological response. You have this anti-insulin action, you have promoting catabolism, all of these hormones, impaired insulin secretion from epinephrine, and decreased glucose utilization from cortisol growth hormone epinephrine. Now, the pathogenesis of this, the serum glucose is elevated, but it generally is not as high as in the hyperosmolar non-ketotic conditions. So usually around less than 800, but above the normal range. 200, 120. Impaired glucose utilization in peripheral tissues, increased glycogenolysis, and increased gluconeogenesis. So breakdown of protein and breakdown of fats to create glucose. That's gluconeogenesis. We get increased breakdown of glycogen stores. So the storage form of starch in our muscles and in the liver. So we're breaking down glycogen, and impaired glucose utilization despite the fact that we're making glucose from protein and we're releasing glucose from our glycogen stores. We can't utilize it by the tissues. So this leads to really this response that the body is starving. And the hormone, the epinephrine, the glucagon. So we have hepatic gluconeogenesis promoted by increased delivery of our precursors, again, alanine from breakdown of proteins, glycerol from breakdown of fats. An increased secretion of glucagon due to the loss of inhibition by low insulin levels. And glucosuria, release of glucose in the urine because of the rise in serum glucose. Once it reaches that 180 milligram per deciliter threshold, you start to spill glucose into the urine, and it's going to pull body water with it. And as it pulls body water with it, you get more and more dehydrated. So I want to go through three kinds of cases that we saw in our endocrine specialties, and they're different aspects of DKA. So I want to just present to you the utilization of beta-hydroxybutyrate and how useful it is to kind of manage some of these patients. So the first one was this 13-year-old Caucasian female. She was overweight, no past medical history, a family history of type 1 diabetes, so she was not diagnosed at this point in time. But she came into her primary care physician, 2-week history of polyuria, polydipsia, 20-pound weight loss. She couldn't get enough to drink, was complaining of waking up several times a night to urinate. Her capillary glucose was 444. Her urinary ketones were 4+, and she was transferred to the emergency department from the clinic. And on admission, her pH was 7.2, so she was acidotic. Her serum glucose 478, so it was continuing to rise. Bicarb was 11. Anion gap, she had an anion gap acidosis, 33. Her beta-hydroxybutyrate was 8.46, and her sodium was 137, corrected for the dehydration and hyperglycemia of 141. Second case that we'll come back to at the end, 58-year-old African American. This is an obese individual, 39 kilograms per meter squared. No previous history of diabetes, but he ended up in the ED. 1 week history of fatigue, polyuria, polydipsia, blurry vision. His capillary glucose was 300. Hemoglobin A1C 16.1, which is rather impressive. Bicarb was 17. Anion gap just slightly elevated at 19. Positive urine for ketones and glucose. And his beta-hydroxybutyrate very severely elevated, 6.86. And the third case I want to kind of profile here, 57-year-old Caucasian male, poorly controlled type 2 diabetes, past history of reflux esophagitis, alcohol abuse, cirrhosis. He presents to the ED with hematemesis or blood in his vomit, abdominal pain, recent increase in alcohol consumption. His girlfriend had left him and he went on a binge. He'd not been eating or taking his insulin since he went on this binge. His pH was acidotic, 7.33, just at the bottom of the normal range. Glucose just mildly elevated, but an impressive bicarb anion gap as well. His lactate was elevated at 11. His beta-hydroxybutyrate was elevated as well at 2. His blood alcohol was 209 milligrams per deciliter. And his that's a 0.2 percentage, and his urinalysis was a 2+ for ketones. So we'll come back to those after we explain what is ketone bodies and how do we test for them. So ketone bodies are 3 water-soluble compounds produced as byproducts when fatty acids are broken down. There is acetone, acetoacetate, and beta-hydroxybutyrate. Now normally the body breaks all of these ketones down to carbon dioxide and water. But as you're breaking down fats, your aerobic at respiration can't keep up with this, and you end up building up ketone bodies as a byproduct. So the buildup causes this acid-base imbalance because acetoacetate and beta-hydroxybutyrate are both acids that are unmeasured in the bloodstream. So if you're looking at just an electrolyte panel, you're not going to calculate, what you will calculate actually is an anion gap, an unmeasured rise in these anions. Now normally patients have a beta-hydroxybutyrate ratio to acetoacetate of 1:1. But in ketoacidosis it shifts, and beta-hydroxybutyrate outnumbers acetoacetate by about 6:1. So beta-hydroxybutyrate is favored in the ketotic state. This just shows the metabolic pathways. You basically, in the absence of insulin, you break down free fatty acids to acetyl-CoA, which is a 2-carbon chain unit. This then is converted to HMG-CoA reductase, will eventually go on to cholesterol synthesis. But if you're using this breakdown for ATP, you don't need to build up that much cholesterol. You basically, through HMG-CoA lyase, convert it to acetyl-CoA, which can give you more ATP, and acetoacetate, which in the lungs converts it to acetone, or through beta-hydroxybutyrate dehydrogenase to beta-hydroxybutyrate. Now, when insulin is returned and the body turns to a more normal metabolic state, these can actually be reversed, acetoacetate and beta-hydroxybutyrate, converted back and converted to CO2 through the TCA cycle. You just need respiration and a normal metabolism and the presence of insulin to move this in the opposite direction. So it can move in either direction. Absence of insulin, this direction. Presence of insulin, that direction. And again, as we mentioned, presence of insulin, you're going to take these 2-carbon units and build up free fatty acids as storage for later use of ATP. So, ketone bodies. Remember, beta-hydroxybutyrate accounts for more than 75% of all the ketones seen during ketoacidosis. Normal levels are about 0.02 millimoles per liter. Historically, ketoacidosis is diagnosed and monitored with nitroprusside. It's the colorimetric reaction. These are the KetoSits, the ACE test, the Bayer urine dipsticks. It's semi-quantitative. The darker the purple color, the more beta-hydroxybutyrate or the more ketones that are present. Now the problem is that nitroprusside does not detect beta-hydroxybutyrate. It only detects acetoacetate. So if we go back here and we look, remember this outnumbers acetoacetate nearly 6:1. So if you're looking at nitroprusside, you're only detecting acetoacetate and you're missing the beta-hydroxybutyrate. So depending on what stage you find this individual, they may be early on and you may see a false negative. You can also have false positives because of drug complications, drugs that the patient may be taking in interference with the test. So here's acetoacetate, nitroprusside reaction detects only the acetoacetate portion. You see it turns purple in the presence of acetic acid. So in severe ketoacidosis, I mentioned the favor of beta-hydroxybutyrate. Nitroprusside test could be weakly or negative depending on the stage that you actually find this person in ketoacidosis. And when ketoacidosis improves, the beta-hydroxybutyrate to acetoacetate ratio actually backs up, favors acetoacetate, and as it does that, you're going to get a stronger nitroprusside. So during recovery, the nitroprusside reaction may actually increase while the beta-hydroxybutyrate levels are decreasing. So it'll give you a kind of false sense that the person is actually getting worse when they're actually recovering. And you have to remember certain drugs can cause a false positive reaction. So how do we measure beta-hydroxybutyrate in the laboratory? There's a lot of different types of methodologies. I mentioned the nitroprusside, rapid, but several limitations. False negatives because it only detects acetoacetate and not beta-hydroxybutyrate. And the drugs L-DOPA, captopril, other ACE inhibitors can cause a false positive reaction. Now, gas chromatography, capillary electrophoresis, on the other hand, is very specific, but it's not available in most hospitals, particularly many community hospitals, and it takes a rather long time to prepare the sample, get it injected through a gas chromatograph or capillary electrophoresis. So it's rather complicated, not well utilized to measure these. Fortunately for us, there are enzymatic methods that are rapid, have minimal cross-reactivity with interfering drugs, and can be performed on our automated equipment in the core laboratory, and some point-of-care testing devices. The enzymatic methods have comparable sensitivity, about 98% versus 98% to nitroprusside methods, but far superior specificity. You see 79% for the enzymatic methods compared to 35% for the nitroprusside dipsticks. These are a couple of different ones. There are actually glucose meters out now that can run ketones on there and give you a kind of semi-quantitative analysis of beta-hydroxybutyrate. There are the StatSite or earlier GDS methods. There is also the colorimetric. Again, you have beta-hydroxybutyrase that takes beta-hydroxybutyrate, forms acetoacetate, and it is the NADH formed that then changes the color with a diaphrase, and it's that color change that is proportional to the concentration of beta-hydroxybutyrate in the patient sample. Normal, as I mentioned, about 0 to 0.3. Ketosis greater than 0.3, and possible ketoacidosis as you get into 5. Now, I want to leave you with some of the guidelines by the American Diabetes Association. These were published in January of 2004. Recommendations, consensus recommendations came out that said blood ketone testing methods that quantify beta-hydroxybutyrate, the predominant ketone body, are available and preferred over urine ketone testing for diagnosis and monitoring ketoacidosis. There are home tests for beta-hydroxybutyrate that are also available. And in 2011, they revised those and made it even stronger and said that blood ketone determinations that rely on nitroprusside reaction should be used only as an adjunct to diagnose DKA, should not be used to monitor DKA treatment. Because as I showed you, they can give you a false sense that the person is actually going downhill when they're actually recovering. So specific measurement of beta-hydroxybutyric acid in blood can be used for both diagnosis and for monitoring of treatment. Now, we talked about DKA, we talked about diabetes and ketone bodies. What about other causes of ketoacidosis? I kind of alluded to this earlier in my talk. Malnutrition, alcoholism are probably two of the largest prevalence. Alcoholics have decreased carbohydrate intake. They forget to eat. They're too busy drinking. So because of that, if you're not taking in glucose, you have reduced insulin secretion. That leads to increased glucagon, and you go into what appears to the body as a fasting state. So alcohol also precipitates inhibition of gluconeogenesis. So it stimulates lipolysis. You start to keep breaking down the fats, but you're not going to form the glucose out of those fats because alcohol inhibits that. So you end up breaking down more fatty acids, and you see higher ketone bodies. You get a high anion gap metabolic acidosis, elevated osmolar gap, in addition because of the high alcohol content, and hyperglycemia can occur, but not usually as high as the levels seen in DKA, because remember, alcohol's inhibiting the gluconeogenesis. If glucose is not elevated and beta-hydroxybutyrate is increased, it can also be due to starvation alcoholism. up to 90% of the ketones in the alcoholic situation is beta-hydroxybutyrate. Other uses, we didn't mention about gestational diabetes, but obviously you can have increased ketones in gestational diabetes, as well as monitoring DKA therapy. I mentioned beta-hydroxybutyrate as an adjunct to monitoring diabetic control. What about in the ED? There is one known problem with all glucose meters, and this is a complication because our physicians, and as the patients back up in the ED, all of the ED docs want to move the patients through the ED more rapidly. They want to kind of turn over that bed, either admit them into the hospital or discharge them. So we were having problems where patients were getting backed up in the ED, and the physician said, well, what if we get a urine dipstick on everyone who walks through the door and a glucose finger stick? Because that could tell us right off the bat some of these patients that may have high glucose. We can get them seen into the clinic and kind of move some of these patients through. And we waved our hands and said, wait 1 second, because on the package, the fine print and the package insert of all the glucose meters actually warns that you may have erroneous results with patients, and particularly what it states is test results may be erroneously low if the patient is severely dehydrated, severely hypotensive, in shock, so you can't do these with patients who have had a recent trauma, or in a hyperglycemic, hyperosmolar state, with or without ketosis. So we warned our physicians about this, and they says, we don't believe it, prove it to us. We says, we have these glucose meters, we need to be able to manage DKA in the emergency room before we can find a bed for them, and they need hourly glucoses, they need insulin to kind of reverse the problem and get them on the pathway of recovering. So poor peripheral circulation, we kind of theorized may be part of this. Acidosis, we thought, even the viscosity of the blood may be something to consider, but we don't really know what the cause of the problem is. But here's some of the patients that we saw. The bright green here is actually our point-of-care glucose meter. That's the point-of-care glucose. The dark blue is the laboratory, collected at the same time. This patient went up to almost 1,800 milligrams per deciliter, but yet the glucose meter never got over 300. We had other patients. This is a really good one here. The glucose meter was right around 500, 550, and we were reading somewhere around in 1,100, 1,200 range from the main laboratory. As we rehydrated the patient, you can see the main laboratory glucoses came back down, but the point-of-care glucoses were all over the map and significantly lower than what we were detecting in the laboratory. And likewise, this one shows it quite well as well. Here's a patient who in the main lab was reading somewhere around 800. Point-of-care glucose was around 400. As we rehydrated, it slowly crept back down, and they started coming back together and correlating well after that patient got rehydrated and pH was normalized. So it is a problem. It's something to be aware of if you're using a glucose, and it's not just the meter we were using, that model. It is a warning in all of the glucose meters. Be careful of using them on the floors or even in the ICU after you admit, because we had a couple of cases where our physicians came back and practice managers and said, what is wrong with our glucose meters? Because they're just not reading accurately in the ICU for these certain patients. And lo and behold, it was because they were DKA. And they had failed to notice and recognize that this particular limitation. So just to tell you the study that we actually looked at, this was at Bay State when I was working with Tufts. We're a 50-bed ED, level 1 trauma, about 100,000 visits annually, one of the top 3 busiest EDs in the Northeast. The ED staff needed this hourly glucose levels with rapid results to manage insulin dosage on DKA patients that had not yet been admitted. And the lab, turnaround time was more than an hour. It was about right at an hour. And, with hourly glucoses, waiting an hour, you were almost an hour behind in terms of treating this patient as to where the patient currently is. That's why you needed a rapid glucose. We could understand that. We just needed to find them a rapid glucose that worked for them and didn't have those limitations. So we investigated these differences. We took 54 consecutive blood draws from suspected DKA patients. We collected a green top heparinized tube off of them, took a drop of the blood immediately after collection, ran the glucose meter with it, and then sent the blood to the laboratory to be analyzed. And we also collected data that confirmed the diagnosis, bicarb levels, degree of metabolic acidosis, and beta-hydroxybutyrate levels on these patients. Demographics, they're aged 10 to 86 years, 63% female, 46% final diagnosis of DKA. Conclusions from our physicians after they saw the data: don't use the glucose meter in patients with DKA. They happily said, okay, now we understand. The lab does know what they're talking about. We have to believe the package insert. We shouldn't use these things. Point of care severely underestimated the lab glucose in 50 of the 54 cases, 93% of these cases. Only 52% of the point of care results were within plus or minus 20% of the lab. The higher the glucose level, the greater the difference. And there was no association between acidosis and the glucose correlation, because we thought maybe it's just the acidotic patients that we need to be aware of. So we broke them down and we looked at acidosis. Here's the correlation. These are the ED point of care glucose here on the y-axis. The x-axis had the reference lab glucose. The red triangles here, or diamonds, are acidotic patients, and the blue are not acidotic, but you can see deviations in both of these. And as you look at it a slightly different way, here's no and here's yes. And you can see that there's this cluster here that still shows significant differences, 100 to 200 milligrams per deciliter difference between the main lab and the point of care glucose. And we published that, actually it was in 2009 in the Journal of Emergency Nursing. But it's something I'd like to talk about as I talk about DKA, that beware that other methodologies can show interferences. And if you have a beta-hydroxybutyrate method and you can get a quick diagnosis on these patients, you can prevent some of the wrong use of point of care testing on these patients. Now, what about other uses of ketone bodies? What about ketogenic diets? Ketogenic diet has been used since the early 1920s as a treatment for epilepsy. It fell out of popularity with the advent and development of anticonvulsants in the 1930s to 1950s. But there are a number of children that actually have refractory epilepsy that is refractory to drug treatment, and they continue to have breakthrough convulsions. In particular, there's the Lennox-Gastaut syndrome, and there's been this Charlie Foundation that was funded, a multi-center study published in 1996, marked the beginning of renewed scientific interest in the diet. When I was actually at laboratory director at Hopkins, we had an epilepsy center that was studying these ketogenic diets, and they used the GDS, the meter that actually ran beta-hydroxybutyrate right there in the clinic, and they tried to keep them into a range that was not severely ketotic, but also above the normal. So they had a particular range at which they found if you can keep their ketone bodies within a certain range, their epilepsy symptoms dropped off. It was basically a high-fat, adequate protein, low-carbohydrate diet designed to mimic the effects of fasting. So it increased the ketone bodies because they became the primary energy source for the brain, where you were basically breaking down fat and protein here. Well-documented and unblinded studies to improve seizure control in children with difficult-to-control seizures. In general, at least 50% reduction in seizure frequency in 50% of the patients that were studied. The mechanism is still unknown, so it wasn't successful in everybody, but it was successful in some of the patients. In the past, they monitored the treatment for compliance with the nitroprusside dipstick method, but got really misleading results. So they published some of these papers, and it was actually Freeman that I worked with at Hopkins with these levels that basically said that the ketogenic diet seizure control correlates better with serum beta-hydroxybutyrate than urine ketones. So it may be one other use that you may find for the drug level or the beta-hydroxybutyrate levels. What about other future uses? What about the Atkins diet? This is one of those popular high-fat or high-protein, low-carb diets popularized by Dr. Robert Atkins in the 1960s. Basically restricts carbohydrates, causes metabolism to switch to burning fat, promotes ketosis. So there's been some mixed literature over this, finds patients on the Atkins diet lost similar weight at 1 year compared to other diets and exercise plans that didn't increase the amount of lipids in your bloodstream. Controversy over whether this diet actually promotes coronary disease, cardiac risk. I believe he dropped on a sidewalk somewhere in New York. I don't know whether it was because he was an advocate of the diet or not. Maybe he wasn't monitoring his beta-hydroxybutyrate levels. But whatever, I think it's still very controversial about that. It's known that ketones will produce if you have carb restriction, because you're not taking in glucose, you're going to have to get glucose from something. You're going to have to break down fats and break down protein. So some proponents of carb-restricted diets actually indicate that during induction, ketones will only spill into the urine when excess in blood more than what's used for energy. Some dieters actually never show even trace amounts and lose weight. Others may show gross ketosis. So there's no correlation. This really is not well studied. Urine levels actually are based on hydration status. Most importantly, nitroprusside dipsticks don't look to beta-hydroxybutyrate levels. They only detect acetoacetate, and that may be why some of these studies have been very misleading. But the Journal of the American Dietetic Association in 2005 said urine ketones reflect serum ketone concentrations, but they don't relate at all to weight loss. So the jury is still out on the clinical utility of using ketosis to monitor low-carb diets. But that does not stop people on the internet from selling you something, because they'll sell anything they can get away with on the internet. And I did find this actually for $5.95, which is rather expensive, for 100 test strips. It says, urine ketone test strips. Are you burning fat? Test yourself with Ketone Check, from the top-selling manufacturer of urine test strips. Ketone Check is an ideal way to see if your low-carb diet is working. The Ketone Check Home Urine Ketone Test Kit. Don't buy it. So let's go back and talk now about those three cases before we conclude. Remember, the first case was our 13-year-old patient who showed up complaining that she was getting up in the middle of the night with thirst and urinating several times. She actually was diagnosed with diabetic ketoacidosis. She had positive islet cell antibodies, confirmed her type 1 diabetes. And her family had a history, remember, of type 1 diabetes. She received IV insulin. She was transitioned to sub-Q insulin with improved glycemia, and then discharged home on an extensive diabetic education and teaching plan. At a 2-month follow-up, we had a healthy adolescent girl. Her hemoglobin A1C significantly decreased from 11.3% to 8% at 2 months. Her average 2-week capillary glucose was now 99, which was spectacular. And it just goes, I think the take-home message here with this case, diabetes education is a key part of treatment and prevention of another DKA episode in this patient. So before this, there was no symptoms that she actually had diabetes. And she was actually diagnosed on admission or recognition of the DKA from this one initial incident at 13. Our second patient, remember, was the African-American, obese African-American. He presented with DKA as well, without evidence of antibodies, basically, or this latent autoimmune diabetes in adults. He improved with multiple daily injections of insulin, finally was weaned and stopped insulin altogether because of fasting hypoglycemia. And his meal insulin was stopped as well because he continued to have hypoglycemic episodes. He was diagnosed, remember he was up at 16.2% hemoglobin A1C. Within 6 months, that decreased to a normal 6.2%, even without the insulin. He was diagnosed with glucose toxicity of beta cells. This is basically kind of known as a flatbush. It was recognized in the Flatbush area of New York. The migration of certain people of Puerto Rican and ethnic descent that populated that area of New York were prone to a diabetes of what's called 1B type of diabetes. It's typical of non-Caucasians, called flatbush diabetes, or ketosis-prone diabetes. Atypical diabetes is also in the literature, you'll see this. Basically improves on itself. The pancreas actually goes into shock. It can't produce enough insulin. And with normal euglycemia, normalization of glucose with external insulin, the body normalizes itself, the pancreas gets whole again and sort of recovers and can continue then to keep up with the metabolic process with the patient. Prognosis really depends on their beta cell reserve for insulin and how long they've gone undiagnosed. But the presence of islet cell antibodies is a bad prognosis in these patients, that they're really much more prone to this than a person who is just showing a little bit of imbalance with their pancreas. Most undergo long-term improvement, insulin independence, but some continue to require insulin and have risk of relapse. Just depends on the presence and amount of the antibodies that they have and how much insulin reserve they have. And the third case, remember, was our diabetic who went on a drinking binge. He was diagnosed with metabolic acidosis with an overlying lactic acidosis caused by a combination of his alcoholic ketoacidosis, starvation ketoacidosis because he wasn't eating, he wasn't taking his insulin either, and a possible component of DKA. He was treated as an inpatient in the ICU with hydration, given insulin. His acidosis resolved within 24 hours, his lactate levels decreased, and the patient was transitioned to insulin prior to discharge. Now the problem again, he was recommended keep up with his diet, keep up with his regular insulin, and to stop drinking. So, in summary, I kind of like to just wrap up and say in the past, urine dipstick nitroprusside has historically been utilized to screen and monitor for diabetic ketoacidosis. Still widely marketed method, but it's qualitative and has a number of potential interferences. The present now is plasma or serum beta-hydroxybutyrate, gives a direct quantitative measurement of blood ketones, and provides a better method of diagnosing and managing ketones compared to any cause, whether it's starvation, diabetes, alcoholism, diet. Clinical applications of beta-hydroxybutyrate for screening and diagnosis of ketosis in the setting of DKA, alcoholic ketoacidosis, and I mentioned about starvation. So with that, I'd like to wrap up, and I thank you for your attention, and we'll open it up for questions.
Very good. We have a few clinicians in the audience, and any questions for Dr. Nichols? To me, this is an important test that we've added to our armamentarium. I think 1 in every $7 that we spend in America is spent on diabetic care. Over $1 billion for DKA per year. This is some serious stuff. Anybody have any questions, please?
Yes.
Is an Atkins diet a ketogenic diet, or is it not technically a ketogenic diet?
I don't know if it actually is or not. It is a low-carb diet, so from that standpoint, you are actually eating high protein. But whether you're the thought is you're eating high protein and you have to be metabolizing your fats. But lipids have been shown to increase in these patients. So you are mobilizing fat. Whether you're actually utilizing it is the other question. And that's why some of these, the literature on this is really all over the place. But you have to laugh that people will sell anything to anybody who is willing to buy it on the internet. And the fact that they have ketone dipsticks sold to kind of monitor your ketosis and the Atkins diet doesn't make sense.
Just personally, I've smelled acetone on many people with Atkins diet. It's not uncommon, so that's my experience. Unscientific.
Could you go back to the slide on reversal of the beta-hydroxybutyrate acid?
Oh, sure.
Just let me see that
This was the metabolism.
again.
This one.
Yeah, right. So,
So you have free fatty acids here who are broken down into, remember they're long chain fatty acids. They're broken down into 2 carbon units that can then enter the TCA cycle and be metabolized into CO2 and water with ATP during the breakdown. If you can't keep up with the oxygen, you break down as well on the side chain here and form these 2 carbon units into cholesterol synthesis or break down into acetoacetate, beta-hydroxybutyrate, or acetone. But you can reverse this backwards with the presence of insulin, primarily from acetoacetate back up, or beta-hydroxybutyrate number 3.
so that goes, down below goes simultaneous. You get the beta-hydroxybutyrate, yeah, I know that, the ketone bodies, but what about the, over on the right, what controls that?
What controls this cholesterol synthesis is the HMG-CoA reductase enzyme.
So that's going on simultaneously?
It goes on simultaneously. Yes?
Regarding this figure as well, so insulin goes down, the liver makes ketone bodies, they go to the brain, and then in the brain at least, the acetoacetate is flowing back towards the Krebs cycle.
It
But
is.
insulin's still low, so how how's that happen?
It's partially because of the breakdown. You have glycerol as well that comes off of these breakdown of the storage in the fat cells. So you have triglycerides basically is the storage unit. The backbone of that is glycerol. That gets broken down and creates into sugar, gluconeogenesis, as well as protein that's making sugar as well. So those go in to feed the brain as sugar molecule. And these actually then are taken back in, and they actually function as part of the ATP for the brain as well. The ketone bodies become an energy source as well through these same enzymes. But you don't need the glucose uptake with insulin for the ketone bodies. Remember, you need that glucose receptor with the insulin-mediated glucose receptor on the cell surface to absorb the glucose and utilize it. This bypasses that receptor because they're different metabolites.
Any other questions? Well, thank you very much, Dr.
Thank you.
Nichols. This was very